Okay, so our case study was the chemotherapy extravasation case study. So, just for a little bit of introduction, we have our patient. He's a 58-year-old male who has metastatic prostate cancer, and he was admitted to the floor for chemotherapy via his port. And the medication he was receiving was adriamycin, which is a vesicant. And so, during the infusion, the patient leaned over and felt a sharp pain and burning at the port site. So, the nurse came over and assessed, but she didn't see any swelling in the area, and she was able to get some blood return. So she just decided to continue with the infusion. Then later on, right as the infusion was ending, the nurse assessed and noticed that there was some swelling under the skin. So she stopped the infusion, applied some ice and heat, but the patient was still complaining of pain and redness at the site even hours after the administration. And so she contacted the physician and they ordered dextrazoxane. But the order was delayed due to inadequate stocking on the floor, so the patient actually didn't receive the medication for until hours later. And so the outcome of this is there was a severe extravasation injury, and then the patient needed to have some debridement, some wound care, and skin grafting as a result of this injury.
So for our cause and effect analysis, with the main five categories, the main people that were involved was the float nurse herself, and then I included pharmacy in there as well, just because they are the ones stocking the antidote, and not having the antidote on hand was a problem within the process of getting the antidote administered. The environment, obviously, the float nurse wouldn't have been there if there weren't staffing issues, and then that time delay in getting the antidote, needing it to be carried over. The materials, most of it is just having no antidote to get the vesicant medication um, taken care of. The methods was that the nurse didn't have proper training on an extravasation or didn't know what to look for with extravasation, especially with chemotherapy, and then no proper channels were notified. She didn't notify the charge nurse or the provider until well after things had been already problems had already been started. The equipment, again, lack of antidote, and then um, I know some like ports or IVs have like infiltration sensors. That's not something that this unit has. And then for our root cause, we decided that it was due to a lack of safeguards or standards for training within the float pool, especially for oncology, because if this nurse had been properly trained on oncology protocols and how to give chemotherapy and what to look for with extravasation for vesicants, we felt that this situation wouldn't have happened. So our five whys were the unit was understaffed, which needed the float pool nurse to come in, but she was unfamiliar with the unit. She was improperly trained on the chemotherapy, and then no known extravasation protocol, nothing was posted. So even though the nurse wasn't trained, which was the biggest reason, there wasn't anything that she could have referred to without having proper training. And then that lack of communication between the nurse and the provider.
For our failure mode effect analysis, basically it talks about all the steps that went through that were where there was fail safes that failed. Our first step was that the floor nurse was short staffed, and so the float nurse was needed. Patient then expressed pain at the portacath, but the nurse continued the infusion. The patient complained of pain after the infusion for hours, and that was only when the nurse talked to the charge nurse. And then after that was finally when the nurse notified the physician. The physician came, prescribed the antidote with a dosage time of now. However, 2 hours after, when the physician arrived on the unit, it was not given, and that was because the pharmacy didn't have it on site. Um, you can look through the table and see kind of where I placed the occurrence likelihood, the detection likelihood, and the severity, and then our RPN score related to that. Um, Main actions to reduce this occurrence, I talked about universal training of all float staff on chemotherapy administration, materials about chemo extravasation, and standardizing escalation protocols with extravasation, such as notifying the charge nurse and notifying the patient's physician to ensure that these things don't happen in the future, and then also encouraging pharmacy to have the antidote on site to prevent the delay of transit of medication from an alternative location.
Okay, so now we're going to talk about the QI flow chart. This is basically the way it should have gone, and with proper training, is the process to follow for this kind of situation. So to begin, there was a 50-year-old cancer patient receiving a vesicant for chemotherapy via portacath, and then the first decision that needs to be made is while the infusion is going along, you have to assess for any reaction like pain, swelling, or lack of blood return during the infusion. And if there is not any of those, um, then you continue to the infusion and then you make sure there's not at any point in the infusion any of those symptoms. And then after the treatment is finished, then you also follow up with any of those symptoms after the fact. However, if there's any of those symptoms, even just pain, then you have to stop the infusion immediately. Then you would leave the cannula in position and then try to get as much of the vesicant that's causing the irritation out of the body from the device. And then if an antidote is available, then you would administer it. However, if there was not an antidote available, you'd have to immediately contact the pharmacy and doctor to obtain the antidote. And then you would also administer the antidote through a different vein, not involved in the extravasation. And then you would apply a cold or hot compress. And you can do that for up to 24 to 48 hours after the injury has occurred. And then you would rest and elevate the affected site, allowing for normal absorption or drainage of the extravasated fluids. And then you would follow up with just monitoring the site to see if the condition is improved or if it's worsened. And the antidote has a 3-day dosage period, and so you would also monitor that, and then you'd monitor it for 1 week after, and then 2 weeks after, and then as necessary to make sure that no severe damage has been.
Okay, so as we discussed in our 5 whys, training was a big part of the problem here. So for our plan, we've decided that the float pool educator will arrange an in-person training on chemotherapy drugs with the intent to have an annual review of the information as well. So that'll be the nurse educator that's doing it at the hospital. There'll be 3 days to choose from, and all staff will be required to complete the training. And those who haven't completed the training won't be floated to the oncology unit just to make sure we ensure patient safety. And to be able to measure our results, we'll have everyone pass off with the nurse educator right after the training. And then any float pool nurse that is sent to the oncology unit will answer a short survey with the following questions. Did you administer any chemotherapy drugs on your shift? If so, were there any complications with the drug administration? And if so, what happened and how was it resolved? And we will be implementing that plan as soon as possible.
So this is our action plan, and we wanted to keep it simple just to start out to see if we could fix a problem early and easily. And so kind of like what Chris was saying and Stacy as well from earlier, we just first wanted to properly train all float pool nurses. All of them will be trained in chemo as well as just the oncology unit in general, as well as improve the communication. Stacy talked about how there's a proper line of who to talk to if things go wrong, notifying the charge nurse and so forth. So just making sure that all the float pool nurses are familiar with it. And then like Crystal said, there's the post-training survey. And so making sure that they feel comfortable with the training, as well as filling out a survey after they are on the floors to see if anything went wrong and how to improve that. And then the second part that we wanted to do is have reminders at the nurses' stations. It was mentioned that there wasn't super clear protocol for the nurses to follow, and so we want to make sure that's listed for everyone to see, and also to help the float pool nurses to have a what to look for if things are going wrong, to help them realize if something is infiltrated or a patient is at risk. And then just the last step is that we'll assess if the plan was successful or if we need to readjust it as necessary.